and when I arrived it was clear that things were not good. The reason for this was that all the lights had gone out. And so the boss had this thing which was on wheels with a thing big like a car battery and one bulb. So this is not ideal for complex vascular surgery. I, being the mere boy, was afforded a torch, which was held obviously some way away because you couldn't get that close. You'll be glad to know the patient did extremely well, so this may be a way to do it in the future. We also had an early experience with morbid obesity, or at least one of my colleagues did. A very large gentleman came in. In fact, in those days, there were no special facilities for such patients. And he had to be put on 2 adjacent tables. This isn't actually quite as easy as it sounds. So my colleague started to operate for appendicitis, and he made the usual incision. He went through quite a lot of fatty tissue, kept on going through a lot of fatty tissue, came to some tough stuff which he thought was probably a bit of fascia, so he incised that and suddenly realised that he was looking at the black plastic of the operating table. In other words, he had missed the abdominal cavity completely and had just sort of tunnelled through the side wall of the abdomen. He retraced his steps and found the appendix, but naturally he never recovered from this and became an orthopaedic surgeon. I then moved on from there to be a consultant at Benenden. This was actually, when I went there, a very busy hospital with well over 200 beds. We did a phenomenal amount of surgery, and one of the great advantages was, due to the fact there were virtually no administrators, if you wanted equipment, you just got it. And so one of the advantages was being able to start doing keyhole surgery. In fact, one of the first hospitals in the country to do this, because having been on the course, we simply went back to the hospital and started performing the surgery. In most cases in the NHS, people did the course and they then went and ordered the equipment and waited for 5 years and then eventually got round to doing it. I wanted to read you a little passage on the subject of keyhole surgery from the wonderful and original Doctor in the House book, which I'm sure you've all read. I'm sure if you haven't, you've seen the film, and you probably know that this is an autobiographical account of Richard Gordon's experiences as a medical student at Barts in the 50s. This is Sir Lancelot Spratt's ward round. Sir Lancelot pulled back the bedclothes like a conjurer revealing a successful trick. "You just lie still, old fellow," he boomed cheerfully at the patient. "Don't you take any notice of what I'm going to say to these young doctors. You won't understand a word of what we're talking about anyway. Take his pyjamas off, sister. Now you, my boy," he continued, gripping me tightly by the arm as I was the nearest, "take a look at that abdomen." I stretched out a hand to feel the patient gingerly in the region of the umbilicus. I noticed his skin was covered with goose pimples and twitched here and there nervously. "Take your dirty little hand away," roared Sir Lancelot, flicking it off the surface of the abdomen like a fly. He paused solemnly and continued in a heavy tone, wagging his finger. "The first rule of surgery, gentlemen, eyes first and most, hands next and least, tongue not at all. Look first and don't chatter. An excellent rule for you to remember all your lives. Now look, boy, look." I gazed at the abdomen for a whole minute, but it appeared no different from any that might be seen on Brighton Beach. When I thought I'd inspected it long enough to satisfy the chief, who rose uncomfortably above me, I diffidently stretched out my arm and prodded about with my finger. Do some more, Sir Lancelot began again. "You're not making bread. Remember, a successful surgeon must have the eye of a hawk, the heart of a lion, and the hand of a lady. and the commercial morals of a Levantine usurer, muttered Grimsdyke under his breath. With a glow of relief, I finally discovered the lump. It was about the size of an orange and tucked under the edge of the ribs. We lined up and felt it one after the other, while Sir Lancelot looked on closely and corrected anyone going about it the wrong way. Then he pulled a red grease pencil from the top pocket of his coat and handed it to me. "Where are we going to make the incision?" he asked. By now the patient was forgotten. It was the lump we were after. Sir Lancelot had an upsetting habit of treating the owners of lumps as if they were already rendered unconscious by the anaesthetic. I drew a modest line over the lesion. "Keyhole surgery," roared Sir Lancelot with contempt. "Damnable! Give me the pencil." He snatched it away. "This, gentlemen, will be our incision." He drew a broad, decisive red sweep from the patient's ribs to well below the umbilicus. "We will open the patient like that, and then we can have a good look inside." Well, fortunately, I have not shared his view. I've spent probably most of my time trying to do operations through the smallest conceivable incisions. This obviously started off by doing urological operations through the water passage or the urethra, and expanding that into keyhole surgery, first on the gallbladder, the appendix, and various other structures, but finally moving on to the kidney. We formed a very august and internationally recognised organisation for the promotion of keyhole surgery in urology, which rejoices in the celebrated name SLUG. Now, SLUG stands for the Southern Laparoscopic Urology Group, which nobody remembers. This acronym was reached very late at night in the bar of the Grand Hotel at Innsbruck. The idea basically is that when this first started off, we met to talk about our difficulties rather than our successes, and is actually a model for how to get it right. I'm delighted to say that this is now a big thing in America, where previously surgeons never admitted they had any difficulties at all. After leaving Benenden, I went to work at the Queen Elizabeth Hospital, Woolwich, and Guy's. The nice thing about Guy's is, of course, they've got plenty of money, and so we're able to afford a robot. Now, I don't know if any of you know about robots, but it's actually not a thing that looks like something out of a scientific program. It's actually a console with cables that go to the instrument. So it's remote control rather than actually a robot as such. The main advantage of this is that the instruments controlled by the console through the cables are capable of complete revolving at any angle, which is known as a degree of freedom, and this is obviously much greater than the human wrist can manage. So it's actually much easier to use instruments for dissection inside the tummy with a robot. The one problem is they cost £1 million. The other thing that we started doing, guys, is to teach surgeons using simulators, and there are very good anatomical models now made of polymers, which are in every way similar to human tissue, with one exception, the lack of blood, which of course makes it quite easy, but it does give them the idea before they get on to real patients. We then moved on to a thing called LESS, which stands for, I'm afraid they're all acronyms, it stands for Laparoendoscopic Single Site Surgery. And the idea here is if you are particularly worried about the cosmesis, you can, for example, remove a kidney through the tummy button. It's a bit of a struggle, but it can be done. And the first case I did was a well-known model, who is happily still a well-known model. I think one has to say that keyhole surgery has its applications. It is not absolutely indicated in every single case, and there may be cases where it's not possible. and you certainly should not persist with it if it's not safe. As a sort of spin-off from this, having appeared in the Daily Express of all things, I was contacted by the director of Holby City. Now, these programmes do really try very hard to get the accuracy, and they wanted to know how you put a patient having a keyhole removal of the kidney on the operating table, because this was in one of their upcoming programmes. I offered to go and show them, but they said, actually, we're based in Bristol, so you probably won't have time, which was true. So they said, well, it's very kind of you, so I sent them some pictures and so on, but is there anything we could do for you? So I said, well, there is really. I'd like you to make all the nurses in my operating theatre look like yours. There was a long pause because the director was a lady, and she said, it's funny you should say that, because all the nurses we talk to say they want their doctors to look like ours. So I guess you can't have everything. I just wanted to conclude by making some comments about things that have got better in surgery and things that are worse. I think there's no doubt that many of the technical advances are hugely important for patients. As I said earlier, anaesthetics is hugely better. It's very rare now that someone is simply not fit to have an operation, and people recover remarkably quickly. In fact, I went to see a friend of mine this morning who had a brain tumour removed at King's on Thursday around late morning. At tea time, he was sitting up demanding sandwiches. Even 10 years ago, he would have been on a ventilator in intensive care for probably 2 or 3 days. So this is a huge advance. Keyhole surgery obviously is important because by not making a large incision, you allow people to recover and mobilise much more quickly. It's actually the incision people struggle to recover from after surgery rather than the surgery, because it affects the way your muscles work or don't work, and particularly the way your chest works or doesn't. So that's been a great advance. I think on the downside, I would say that having started off life with a contract of continuous employment, I don't agree that the European Working Time Directive, which limits doctors to very short periods on duty, is either desirable or necessary. You can't do surgery on a shift basis, and it's not a 9-to-5 subject. And I think the problem is that the handover between one lot of doctors and another is hopelessly inadequate due to lack of time. So I would like to see that abolished, and I would like a much more sensible approach to the time you spend on duty. If you want to be a surgeon, you don't want a 9-to-5 job, or if you do, you're in the wrong job. I would also like to pay tribute to all the many wonderful people I've been able to work with from all over the world, and I'm particularly pleased to see that nowadays there is a huge increase in the number of women in medical schools. One needs to make sure, of course, that these large numbers of very dedicated and clever ladies stay in the profession by allowing them flexible working. It's a slightly sobering thought that at the moment 70% of medical students are female, and well over 50% of GPs are female too. So if we don't look after women in medicine, we won't have enough doctors. I thank you for your attention. I have been asked if I would be happy to answer questions, and the answer is definitely yes. So are there any questions?